Good afternoon and welcome to today's presentation, Colorectal Cancer, a Complete Guide. The information presented by the expert is not to be used as legal advice and does not indicate a working relationship with the expert. All materials obtained from this presentation are merely for educational purposes and should not be used in a court of law sans the expert's consent, i.e. a business relationship where she or he is hired for your particular case. In today's webinar, Dr. Cohen will discuss colon and rectal cancer, GI signs and symptoms, standard of care guidelines, and informed consent. To give you a little background about our presenter, Dr. Stephen Cohen is a board-certified colon and rectal surgeon with over 2 decades of experience. Not only does he continue to practice evidence-based medicine and surgery, but he has made teaching, training, and educating young surgeons his ultimate long-term goals. Dr. Cohen has been involved in the field of forensic medicine since the early 90s and will help guide you on both standard of care and possible causation in many aspects of colon and rectal surgery. Attendees who require passcode, the word for today is colorectal. During the Q&A session, we ask that you enter this passcode into the Q&A widget for CLE reporting purposes. The Q&A is located to the left of your screen. Please remember that if you're applying for CLE credit, you must log onto your computer as yourself and stay for the full 60 minutes. You are also required to complete the survey at the end of the program. Please note that CLE credit cannot be given to those watching together on a single computer. Tomorrow morning, we will send out an email with a link to the archive recording of the webinar. The slides can be downloaded from the resource list located at the widget at the bottom of your screen. Thank you all for attending today, and Dr. Cohen, the presentation is now turned over to you.
Thank you very much, and I appreciate you all taking the time to listen to something very near and dear to my heart, which is colorectal cancer. And many of the things that we're going to talk about today may help you decide if a case is worth either accepting or certainly defending based on standard of care and what the evidence is showing. So I certainly don't have any particular affiliation with anything. I'm going to give you my background a little bit. So I actually was raised in Southern California. Went to college and medical school at UCLA, for those of you that know where California is located. I spent 5 years doing general surgery at Boston University and then a fellowship in colon and rectal surgery at the Cleveland Clinic in Fort Lauderdale, mostly because the winters are much better than Cleveland, Ohio. I then spent the next 20 years in the private sector in a very large, busy colorectal practice, and now have found my way to the VA Medical Center in Richmond, Virginia, again, teaching, training, educating medical students and residents, and all aspects of colon and rectal surgery. So I actually stumbled upon the field of forensic medicine after I received a subpoena as a third-year resident about explaining that this gunshot wound patient of mine, since I was the emergency room surgeon, or resident, actually had brains on the bed and how I knew it was actually brains. And I really thought that was kind of neat because, as you know, medicine and law are 2 different things, and it was a whole different world. But as I became a specialist in colon and rectal surgery, I was asked by many different individuals to opine on standard of care, what's indicated. Certainly, I was doing 10 times the amount of a particular operation, like either hemorrhoid surgery or anorectal surgery or colon cancer. And if and when there was a problem, I was asked about, was it standard of care? Did the provider or organization meet the standard of care, and why or why not? And I've always been involved in teaching, training, and educating, and I always seem to get this question, especially when I'm on the plaintiff side. Why are you testifying against a doctor? Doctor, why would you do that? And real simply is that, initially I was asked a lot of defense side, but, the whole process of the medical legal arena cannot function without physicians or nurses or someone in the field of medicine to explain to the jury, to the judge, to the attorneys, because you all didn't go to medical school. So my goal is to try to take very complex medical issues that sometimes we fight amongst ourselves as doctors because there's different ways of doing things, and trying to explain it in a logical sequence about what happened. Did somebody meet the standard of care or did they not, and what the reasons are for that. And not only have I been involved in the teaching, training, and educating, but at each level along the way, and currently what I'm doing now is on peer review committee. And peer review, as you know, is protected information, but we evaluate each other. And I really think that as the years have gone on, it has made me a better doctor to know who's looking over my shoulder, what's the right thing to do, because sometimes it's easy to get caught up at midnight to talk yourself out of getting out of bed to go evaluate the patient. So what I want to talk a little bit about today specifically is going to be colon and rectal cancer. There has been a change in the guidelines of who we offer colonoscopy, and this will play into a particular case, as we'll talk about. What are some of the different GI signs and symptoms that are important? When does it meet criteria? What is standard of care to performing a colonoscopy or some type of imaging study? What is the standard of care in colorectal issues? And we'll talk about the guidelines as well as some of the informed consent. So let's talk about colorectal cancer. If we're talking about incidence of colon and rectal cancer, it is number 3 in men and women. So in men and women, lung cancer is still number 1. Number 2 in men is prostate, and we're talking incidence. Women, number 2 is breast. And in incidence, it's colorectal cancer across the board, men and women. The problem with colorectal cancer is that it is, even though number 3 in incidence, it is the second leading cause of cancer death in both men and women. Listen, the older I get, the chance of me getting prostate cancer is going to be 100%. Most men die with prostate cancer. They don't die of prostate cancer, very similar to breast cancer. This country, 2017, over 130,000 individuals will have a new diagnosis of colon cancer, and nearly 50,000 will die from colon cancer. Normally, we see it in those individuals that are older, and the older I get, that's not that old anymore. However, there has been a recent trend that we are seeing of younger individuals developing colorectal cancer, and that's why the guidelines in 2018 have changed. But you may have seen this in the New York Times. This is less than a year, a little more than a year ago, that talks about the higher incidence of younger individuals with colorectal cancer. And that's one of the reasons why we're really advocating for younger individuals. The difference between colorectal cancer and some of the other cancers, obviously, is number one, it's preventable. Most colorectal cancers start from an abnormal growth called a polyp. A polyp is an abnormal growth. We don't know why people get them, but if I can take your polyp out before it turns into a cancer, I have cured you. And that's very different than breast cancer. That's very different than lung cancer. Lung cancer could be early, but you're going to have we don't have a precursor to it, unlike colorectal cancer. There's definitely the polyp to cancer sequence, and what I will show you is in terms of survivability of colorectal cancer, the earlier we can take out the cancer, the better the long-term chance of survival. Every March is Colorectal Cancer Awareness Month. I certainly hope those individuals that are listening to me that are over the age of now 45 have had their colonoscopy. There is absolutely no excuse to not get this test. I will tell you, I had mine. I had mine when I was earlier than recommended because I got tired of patients asking me why I haven't done mine yet. So, the worst part obviously is going to be the prep. It's not that bad. It's probably the only way I can get a day off of work, so that was very helpful. But certainly, this is an older slide, but now what we're talking about is a younger age of performing colonoscopy. And colonoscopy is a very straightforward, there's over 14 million colonoscopies done in this country every year by all of us, either colorectal surgeons, gastroenterologists, general surgeons. It is a relatively safe procedure. Those of you that don't know what a colonoscopy, it's a way for me to look inside your colon. There is a big, long, black snake called a colonoscope. Through that channel, there's a light. So it's fiber optic technology that was developed by actually the airline industry by looking at the big jumbo jets. So this fiber optic technology, I can irrigate fluid, I can put an instrument to take a biopsy, I can take pictures, and it's a very good way that colonoscopy is not only diagnostic, meaning I'm using it as a tool to see what's going on in your colon, but it's also therapeutic, because if I see a polyp or an abnormal growth, it's something I can take right out. And this is a picture of a polyp. I mean, there's nothing special about this. This looks like a little tree with a stalk. Most polyps have a chance to turn into cancer. If I can take the polyp out at an early stage, I have cured the patient of that particular cancer. We have different technologies or techniques to remove the polyp, either a hot biopsy forceps technique, or I put some heat and I burn the underlying tissue. Remember, if I just pull this off, it's going to bleed. There's blood vessels in the lining of the colon. So we use electrocautery. This is like a little lasso, like you're lassoing an animal. You wrap it around this thing. You put a little heat on it. It burns. That way, when you take the polyp out and you can suction it right out through the scope, it doesn't bleed behind it. Certainly, some of the risk factors we'll talk about: bleeding, perforation, doesn't happen often, but certainly a known complication of colonoscopy. The reason why we want to take those polyps out is that if those two little polyps you just saw grew to a big daddy polyp, that now becomes a cancer. The time course of that, depending on what you read, is anywhere between about 5 to 10 years. So if you have a polyp today, the chance of it being a cancer next month is 0. It just doesn't do that. There is a predictable growth from polyp, so at some point the cells become abnormal. The polyp grows inside the wall of the colon. As it grows, it turns cancerous, cancer cells. It will then go through the wall of the colon and then spread to what's called the lymph nodes, and the lymph nodes drain the protein out of the blood, bring it back to the heart. Most of the lymph nodes live along the bowel itself. And then as the cancer continues to grow, it can spread to other organs: liver, lung, brain. Those are the 3 most common. And as I told you before, that's how we stage them. So if the colon cancer is all inside the colon, I have a potential to cure you. Okay, and that's stage 1. Stage 2 is through the wall of the colon. Stage 3 is any type of lymph node outside the bowel wall. And stage 4 is spread to another organ. But you can see what the survival rate is. The longer it's there, the more chance it's going to spread. You do not have a long-term survival, and this is 5-year survival data. So again, you don't want to wait for your polyp to become cancer. If you can take your polyp out before it becomes cancer, A, you're not going to get it. And if there's some cancer inside the polyp, I still can potentially cure you. So let's talk about some of the new guidelines, and let's talk about screening. So what are the symptoms of a patient that I would want to screen? And those are all the symptoms you can see there on the slide. And I hope you're seeing a blank slide. Screening colonoscopy means the patient does not have symptoms. okay? That means no blood in the stool, no change in bowel habits, no abdominal pain, no weight loss, zero. Screening. Screening means no symptoms. The recent guidelines have changed. As we talked about, we are seeing younger individuals with colorectal cancer. We want to try to get it before it turns into cancer. And now the current guidelines as of this year, men and women, because actually colorectal cancer is a little bit higher in women than it is in men, it's about 51%, 49%, is age 45. The old guidelines used to be Caucasian 50, men and women, African American 45, now we're down to 45 for everybody across the board, okay? Who do we not screen? So screening, again, means no symptoms. If you have a family history of colon cancer or polyps, and I want to explain this for a second. I have a lot of patients tell me, well, my dad had polyps, but he didn't have cancer, so that's not a risk factor for me. Is it, doctor? That is a risk factor. Okay, let's think about this for a second. Very logical. Listen, colorectal surgeons are not that smart. If your father had a polyp at age 60, and I'm making up the age, and the doctor takes out your father's polyp, and it's not cancer, it's a precancerous type, not cancer, congratulations, you're fine. Remember, if that precancerous polyp in your dad had been there for another 5 or 10 years, it turns into cancer. So the American Cancer Society does not distinguish between a family history of colon cancer or a family history of colon polyps. It's probably a genetic disease. So if you have a first-line, first-generation family member with colon cancer or polyps, that puts you as a positive family history. And I guarantee some of you are thinking that some of your parents probably have some polyps, but nobody has cancer, that you're safe. Well, you're safe if you get your colonoscopy. So family history, we're only talking about first-degree relative. I don't know what to tell you with second degree. So that always comes up too. My grandfather had it. What do? You're in really the regular screening pool, so it's starting at age 45. But first-degree relative could mean mom, dad, brother, sister, or offspring. I had a 22-year-old patient with colon cancer. Neither of her parents had been screened. One of them had precancerous polyps. The other one didn't. But it's the same first degree. We don't understand perfectly the genetics, but that's what we decide who gets the colonoscopy. Again, some of the other more uncommon things, family history of familial polyposis. There is an autosomal dominant disease where everybody gets polyps. Personal history of polyps. If you had polyps yourself, that's going to be an every 5-year screening or a look inside your colon. Any history of ulcerative colitis or inflammatory bowel disease. And the other thing that comes up a lot is blood in the stool is not normal. Okay? I'm going to say that again. Blood in the stool is not normal. I cannot tell you the number of patients that come to me that are young, 30s. I have blood in my stool, but I know it's my hemorrhoids. Really? How do you know that? Well, because it's bright red blood. Listen, blood in the stool is not normal. Blood makes us all nervous. It is standard of care to investigate that source of blood. Do I have to do it right away? Absolutely not. Maybe I examine the 30-year-old and they have some hemorrhoids and it sounds like hemorrhoidal bleeding, and I treat the hemorrhoidal bleeding and it goes away and they're fine. That's okay. If that same hemorrhoidal bleeding patient does not improve, that now warrants investigation. Okay? The timing of that, months. I don't have to do it right away. Again, to go from polyp to cancer doesn't happen overnight. Even if my hemorrhoidal patient that I'm thinking is hemorrhoidal bleeding, I don't feel anything on rectal exam, I don't see anything in the office. If I don't scope that patient because for persistent bleeding for 3 months, there's no causation there. Nothing changes in 3 months. Colorectal cancer in general, slow growing, doesn't happen that quick, but certainly that particular patient, you need to make sure they have no other symptoms, your treatment was effective, and they're not having ongoing symptoms. Change in bowel habits. Everybody has a different normal number of bowel movements. Okay, I would like to go every day. I don't. I know my grandmother loves to go 3 times a day. The average number of bowel movements is different for everybody. The textbook says anywhere from 3 times a day to 3 times per week is normal. So whatever's normal for you is going to be normal. So have you had a change? If you're used to going every day and you stop going, now you're once a week, that's a change in bowel habits, okay? So that's important. Unexplained weight loss, obviously, you can have a right-sided colon cancer. That makes us nervous. Anemia. Unexplained anemia, meaning low blood count, in anybody over the age of 50 is a colon cancer until proven otherwise. Okay, I'm going to say that again. If a patient over the age of 50 says, look, I feel fine, but I'm anemic, and my doctor gave me iron, and they're not seeing blood in their stool, and they're not having change in the bowel habits, and they don't have a family history, unexplained anemia is a right-sided colon cancer until proven otherwise. That particular patient needs a colonoscopy. You can have extremely large growths in the right side of your colon, and you're not going to have any symptoms. The right colon is very thin wall. The right colon can almost get the size of my head, and you're not going to have symptoms unless it's blocking the ileocecal valve. The ileocecal valve is where your 23 feet of small bowel dump into that right colon. And if you're not blocking that, you can have an extremely large growth and not know it. Okay, and that's very important. I have seen tons of patients over the year that have anemia for a year and are on iron and maybe even blood transfusions, and they miss the right colon cancer. So unexplained anemia over the age of 50, 45, needs a colonoscopy. I'd rather do the colonoscopy until you don't have colon cancer. Let's get another explanation of the anemia. The other question that always comes up is how long does a patient have to undergo screening colonoscopy? So I had a 95-year-old patient walk into the office a couple of years ago with a diagnosis of colon cancer. So I'm getting a history. She had normal colonoscopies throughout this whole time. She presented with some blood in her stool she got to age 88 and was told by her doctors, you're too old. You've had all normal colonoscopies. You don't need this anymore. You're already 88. You're fine. She goes, okay. Age 95, blood in the stool, anemia, colonoscopy, showed a right-sided colon cancer. So the question is, was she told the right advice or did somebody miss it? And actually, the rule of thumb is, and what the guidelines currently say, is you can screen somebody colonoscopy, up to age 76. Between age 76 and 85, it really depends on what's going on with the patient. If they have a bad heart, if they have some other comorbidities, if they have a shortened life expectancy based on whatever is going on with that particular patient, you do not have to recommend screening anymore, especially if you don't think they're well enough to undergo the procedure. I've had that conversation a lot. They bring in their 86-year-old family member. Would you recommend a colonoscopy? Well, if I find a colon cancer, what are you going to do about it? Nothing. They're too sick for surgery. Then I'm not going to do the test. And I try to emphasize that to the young doctors too. Don't get a test if you're not going to act on the result, as long as everybody's in agreement of what we're doing. It used to drive me crazy when I was a surgery resident, where you'd have a patient come in with a ruptured triple aneurysm that was sick as can be. And the history was 6 months before they were told by the vascular surgeon and everybody, the cardiologist and everybody, listen, you have a big aneurysm. The chance of you surviving surgery is very low. We do not recommend an operation. Yet now they have their rupture. They're in the emergency room with no blood pressure, and we're supposed to whisk them to the operating room to do emergency surgery? Listen, if you're not going to survive elective surgery, I guarantee emergency surgery is not going to go well, and it never did. So, and I think as medicine is going along, there's this whole, and I'm getting off track a little bit, this whole palliative care. We need to be able to have these conversations. Listen, if you're 90, and if I find something, you're not going to undergo treatment, that's fine. That's okay, but we all need to know that. So the guidelines currently state if you're over the age of 86, you do not need colonoscopy anymore. Some patients will want it just in case they find something. As we all get older, that may be an issue to do it. And that's really kind of patient preference, family preference, needs to be documented. I don't need to tell this group that. That's very important. Well, part of the problem with colonoscopy is patients don't want it. I mean, I'm talking to patients almost on a daily basis that, listen, you're 65, you got some blood, you really need the colonoscopy. 40% of patients in this country that need screening colonoscopy are not interested. Not at all. I don't want to do it. I'm healthy, doc. I don't need that. Okay, that's fine. I can't make you do something, but certainly those are the recommendations. The other question that comes up is family history. We all talk about family history, okay? Family history is important. However, out of every colon cancer patient that walks into my office, only 20% of them actually have a first-degree relative with colorectal cancer or polyps. So that's a scary statistic, meaning most patients that present with colorectal cancer, they're the index case. So you can't, if you're listening to this thinking, well, it's nobody in my family, I'm not saying, well, I'm fine, that's not necessarily true. 80% of patients with colorectal cancer are the index case. So don't feel good about yourself just because you don't have a family history. Doesn't really mean anything. And the other problem, as I talked about before, is that some of the symptoms occur late. You can have very large cancers in the right side of the colon. Usually right-sided colon cancers present with bleeding or anemia. Left-sided colon cancers present with obstruction because the lumen, the opening, is smaller. Very big opening on the right, smaller opening on the left. Smaller cancers on the left can lead to obstruction, nausea, vomiting, abdominal pain, bloating. Those are the things we normally see with left-sided colon cancer. Again, the screening updated, the things that we talked about. You don't have to do colonoscopy. Colonoscopy has become the gold standard because it's diagnostic and therapeutic, meaning I can look in your colon, I can see what's going on, I can take out a polyp. Some of these other things are out there. We're doing a big study here at the VA looking at annual FIT, fecal immunochemical testing, looking at or fecal DNA testing, meaning are we able to identify early polyps or cancers looking at stool specimen. I think that's going to eventually not really take over colonoscopy, because if you have a positive fecal stool card, now you need your colonoscopy. Well, if it's me personally, just give me my colonoscopy every 5 or 10 years, and I don't want to deal with stool in the toilet bowl or swabbing it or sending it back. And a lot of patients say that as well.
Thank you, Dr. Cohen. We have now entered the Q&A section, and if all attendees can enter the passcode for today, which is colorectal, and any questions that you have for Dr. Cohen. Our first question is, are most insurance providers supporting an earlier colonoscopy before 45 if elected?
Wait, I missed that question again. Say that again, I'm sorry.
Okay. Are most insurance providers supporting an earlier colonoscopy before 45 if elected?
Yeah, that's a good question. Some are at this point and some are not. I just read an article that some of them are reviewing the data to see if that's being supported. So right now, not 100%, but I think that's coming. And I will tell you, the American Cancer Society, the American Society of Gastroenterology, the Colorectal Societies, they are pushing some of these third-party payers, because in the long run, even though everybody thinks so short-term that it's going to cost them more money, I would rather do a colonoscopy and take out your polyp than a total abdominal colectomy, because that's going to be a whole downstream effect. So the short answer is right now, not all of them. Some are. Hopefully that'll change by the end of the year.
Next question. Please compare a colonoscopy and FIT as a diagnostic tool.
Yeah, that's a good question. So most individuals, an annual FIT test, which, you know, the old stool guaiac cards, the problem with the old cards, like I learned back in the 80s, is that there was a lot of false positives and false negatives because it looked at hemoglobin breakdown from anything, okay? So if I ate a bunch of red meat, that would turn a false positive card. The red blood cells came from the meat. It didn't come from my body. The other thing about the old guaiac cards is that there was a lot of false negatives. Most patients take a multivitamin. Vitamin C commonly will turn the old cards negative. So a lot of false negatives from just taking a multivitamin because they all have vitamin C. FIT test is currently an accepted method for screening for colorectal polyps. But again, the difference is if that card is positive, the patient then needs a colonoscopy because it's a diagnostic tool, not a therapeutic tool.
Next question. How often should young men with UC or Crohn's be screened?
Yeah, that's a very good question. So the incidence of colorectal cancer, and I don't know that I would call that screening. I would really call it, because individuals with inflammatory bowel disease, Crohn's disease, ulcerative colitis, they are higher risk of colorectal cancer. That's thing number one. It's 1 to 2% additive every year once you get to 10 years. So that's high. Okay, as every year goes by, if you have inflammation in your colon, it's going to increase your incidence of colorectal cancer. And the other problem is that when these individuals develop colorectal cancer, they're not garden variety like I showed you that picture with a big fungating mass that's obvious to everybody. They grow in the wall of the colon. So it really is very individualized if and when you have inflammatory bowel disease. Every 3 to 5 years is a ballpark, but it depends on the responsiveness because remember, there's a lot of newer medications out for inflammatory bowel disease where we are seeing complete remission, and if you have no inflammation, it lowers your risk of colorectal cancer.
Next question. Do you have to be referred by a PCP to have a colonoscopy?
Well, that's more of an insurance question. I mean, some insurance companies mandate that, but not all of them. So I don't even know how to, again, that's also jurisdictional. I mean, Blue Cross in one state may be different than Blue Cross in another state. That's up to the insurance company, but, you know, again, once the guidelines are out there, and if that particular doctor, family practice, OB, if they're practicing as the primary care, then it is really their obligation to order the screening colonoscopy, to order the mammogram, to do the PSA testing, whatever is indicated. So that's really up to the insurance company, and it may be jurisdictional.
Next question. Does colorectal cancer show up in a blood test?
It does not. So the common test that we do after you have colon cancer when we take it is called a CEA level. CEA is a protein that can be secreted from the colon cancer cells, but it can also be secreted from other cells, and we use it to monitor for recurrence, but not as an index. We don't use it as a screening test. It is not reliable. It can come from other things. And the poorly differentiated colon cancer, I mean, the cells are so undifferentiated, they don't secrete CEA. So a normal CEA does not rule out you have something in your colon.
Next question. You said a polyp doesn't become cancerous quickly. Is neuroendocrine carcinoma of rectum faster growing than normal?
Usually not. I mean, something like a carcinoid tumor, they're even slower growing, or a GIST tumor. GI stromal tumors used to be leiomyosarcomas in the old days. No, those are generally slower growing than garden variety adenocarcinoma. The two main kind of polyps are adenoma, just what the cells look like, or hyperplastic polyps. Hyperplastic polyps never turn into cancer. So if you have a polyp and it's called hyperplastic, you only need a scope every 10 years if you don't have family history. Adenomatous polyps and adenoma, if left alone long enough, turn into adenocarcinoma, and that's the cancer. Those are the precancerous ones. Most polyps are adenoma. I cannot tell by looking at it. I have to take a biopsy. I have to take the polyp out. I have to send it to pathology. And the reason I'm emphasizing that is I've had patients say, my doctor looked, I had polyps, and they said they were benign, and they just left them there. No. I don't have x-ray vision. I can't tell what they are. So needs to come out, but these neuroendocrine are generally slower growing.
Next question. How effective is a colonoscopy to find the polyps?
Yeah, let's punt on that because that leads into a very good lead into the next section.
Okay. Next question. How effective is the stool test to diagnose stage 1 or stage 2 of colorectal cancer?
Yeah, it depends on the size of the polyp. Most of the stool tests, what we're saying now is those polyps have to be greater than a centimeter. Most cancers are greater than a centimeter, but not all of them. So 90% sensitive and, maybe 90% specificity. Sensitivity is the chance of it actually being there. Specific is that if the test is positive, do they really have it? Generally, those polyps have to be greater than a centimeter.
And our last question for this section, how do you treat an elderly patient who has a growth but cannot tolerate surgery?
Well, it depends what their symptoms are. That's a very good question. I mean, if they're bleeding, it's a problem. And I don't know, not to be flippant, but generally what I say is you're never too sick for the right operation. And I don't mean to be flippant about that. If you're bleeding and I can't stop the bleeding, we as surgery look at risks and benefits. And if the risks outweigh the benefits, we don't do it. If the benefits outweigh the risks, then we do it. If they're obstructed and they're not bleeding, we can actually put colonic stents. There's actually, through the colonoscope, we can put some stents in to open it up so they're not obstructed. But that's a tough problem.
Thanks, Dr. Cohen. You can continue with the presentation.
So some of those were actually great questions. So let's talk about some of the litigation issues that come up in the field of colorectal surgery. So some of the things that we talk about, the biggest one for a colorectal surgeon or a gastroenterologist or anybody dealing with colorectal cancer or colon issues is failure to diagnose. The second one's going to be an injury. If I don't explain it to the patient, that's going to be one. Complications, sphincter injuries. I get asked to review a lot of cases of a routine hemorrhoidectomy, anal fistula, anal fissure. The patient then wakes up incontinent. That's a problem. And then lack of informed consent. So let's talk about a failure to diagnose case and how this plays in. And it'll really lead in very well to the question of how accurate a colonoscopy is. So I saw a 65-year-old patient came into my office with some rectal bleeding, been going on for about 3 months. No big deal, except she told me that 2 years before, she had a colonoscopy. It was stone cold normal, and she brought me the pictures to prove it. Not that I didn't believe her, but she had the pictures with her. I did my typical exam, my rectal exam, and lo and behold, she had a very distal, rock-hard rectal mass that I knew right away wasn't going to be good. Lo and behold, the biopsy showed a rectal cancer. So that case, after I operated on her and we got her through the surgery, obviously came as a medical malpractice case. And the claim from the plaintiff's side was that of a misdiagnosis. It went to a jury trial. The experts disagreed, right? Because what have I been telling you this whole time? The defense was saying, wait a second, I have a picture of her rectum. We had a picture of her rectum. There was nothing there, right? But what did I tell you? The plaintiff argued that, listen, to go from polyp to cancer, and this actually turned out to be a stage 3 cancer. She had positive lymph nodes. So what did I harp on you in the beginning of this talk, right? It takes 5 to 10 years to grow. It's very slow growing. The plaintiff argued, well, wait a second. 2 years ago, it's a normal colonoscopy, and now you have stage 3 colorectal or rectal cancer? Obviously, there was a problem, and the causation was, listen, if the doctor had performed an adequate colonoscopy and found this thing earlier, 2 years is a long time, and obviously on the plaintiff's side, their expert, more likely than not, this is not in the lymph nodes, and her survival is improved. Again, all those graphs that I just showed you. So the question is, and this happens a lot, who is to blame in this case? You have a normal colonoscopy, and a cancer develops 1 to 4 years later. You know that's going to be a setup for a medical legal action. Again, what we talked about, the plaintiff, the inadequate performance was the proximate cause in the delay of the diagnosis, and that delay resulted in progression to cancer and to an advanced stage. So I will tell you, so to answer that question, and that was perfect, whoever's in the audience, is that colonoscopy is not 100%. I know everybody wants a guarantee, but as you know, this is medicine. In medicine, there is no guarantee. There is going to be an inherent miss rate of polyps inversely related to size, meaning the smaller the polyp, the more chance you're going to miss it. The larger the polyp, probably not going to miss it, and also the higher number of polyps. Some patients, I'm there for an hour taking out 15 little baby polyps that are small, but they all come back adenomatous. So they've done some very good studies. So what does the literature show? So they've done some very good tandem studies. So what is a tandem study? Definitely something that you all do not want to sign up for. Tandem study is, in the morning you go to doctor number 1 to do your colonoscopy. You wake up from the procedure. An hour later you go into room 2 and doctor number 2 does a second colonoscopy to see if the first doctor missed any polyps. And what does that show? That this is the percentage of polyps that are actually missed. So in the first study, they looked at almost 100 patients. Polyps less than 5 millimeters, 16% of the time they were missed. 6 to 9 millimeters, 12% of the time they're missed. And you can see the other study down below. So that's a problem. The other problem is, as I told you, that there's a variable growth rate. It takes 5 to 10 years, depending on what you read, to go from cancer to polyp. But once the polyp turns into cancer, it's then got to go through the stages of through the wall of the colon, then to the lymph nodes, then to the spread. Well, so let's go back for a second. So if it takes that long to grow, we know that there's about a 6 to 8 month doubling time in colorectal polyps as they grow. That's standard. So if you have let's go backwards, a 6 centimeter cancer diagnosed 2 years at index with a 6 to 8 month doubling time, that cancer 2 to 3 years earlier was less than a millimeter, right? So what am I telling you? I'm telling you that about 10% of the time, you are going to, and the individual physician is going to miss a small polyp that can turn into cancer in a 2 to 3 year time. This is a known inherent miss rate of colorectal polyps. The other question is, does size matter? I mean, I've seen tumors as big as my fist that have all been located inside the colon, have not spread to lymph nodes, have not spread, and I've seen colorectal cancers the size of a dime, but terrible pathology. All the lymph nodes are positive, so size does not matter. It has no correlation to spread to the liver, lung, or to the brain. And the other problem is that we're learning a little bit more about the genetics of colorectal cancer. Most colorectal cancers, and this is what I learned, 10, 15 years ago, are from chromosomal instability, which leads to that 5 to 10 year growth rate. But genetics have changed, and that's why we're seeing this a little bit more in younger individuals. We can do some special DNA mismatch repair genes looking at the genetics of the individual cancer cells, and what we are finding is that there is a little bit faster growth rate in those colorectal cancers that have these mismatch repair genes, and that's something that can be done by the pathologist to determine if this happened to be a faster growing cancer, and that's important. So the question is, are interval cancer meaning I do your colonoscopy today, but 2 years you now have a cancer, are they based on negligence? And number two, what is a colonoscopy? Is it standard of care, or is it a guarantee that you're never going to have a problem? The standard of care, you all know this definition. You know, what's a reasonable, prudent provider, similar training, how they would take care of that patient under similar findings based on the way the presentation or based on the way the patient is presenting. And it's very important, and I try to make this distinction. Standard of care doesn't really take into account what the outcome or the conclusion would be. I don't know that, right? I can only deal with facts as they come to me, and the standard of care really should be, what is the thought process? If I'm thinking DVT, am I ruling that out? If that test is normal, what's the next step? How is the patient progressing? So standard of care really shouldn't be what the outcome is, because sometimes we have no control over the outcome, even if our thought process is accurate. And as you know, poor outcome, I've had plenty of them over the last 20 plus years, can occur even if you're doing everything right, getting every test appropriately, and working the patient up the right way. The other question that comes up a lot is judgment. Right, Dr. Cohen, doesn't a physician have judgment to make? Absolutely. Judgment's important. But judgment needs to fall within the standard of care. Listen, we argue amongst ourselves at our conferences every week sometimes what the appropriate surgery could have been or should have been or what were the other options. There's options in everything. And if the provider, if the individual is acting within the standard of care, then they do have some judgment based on the certain signs of symptoms of the way the patient presents. So specifically for colonoscopy, and some of these points I want to make at the end because they're important, what are the reasons that I get asked to review charts in terms of colonoscopy specifically? Certainly perforation. Every perforation, everybody wants to sue everybody. Bleeding or medication reactions. And also, you know, did the doctor do a complete colonoscopy? And that's very important. So when I'm doing a colonoscopy, what are some of the standard of care items that need to be checked off the box to make sure I've done a complete exam? Because I will tell you, sometimes we can be fooled. So an adequate colonoscopy, number one, you have to make sure that you get all the way to the cecum. The cecum is the very first part of the colon. It's way down by the right hip. It's where the appendix is attached. It's where the ileocecal valve is located. You need to intubate this area. So if the cecum is not intubated, you can easily have a little colon cancer or polyp missed in this area. So that's what it looks like. I mean, the ileocecal valve there is where the small bowel comes in. We see the appendiceal orifice. There is no polyp or tumor in that field of view, but you need to be able to see that, okay? The other question is, was the prep adequate? Listen, I didn't like drinking all that stuff. I was in the bathroom all night long. I mean, it was awful. But if a patient comes to me and I do a colonoscopy and I can't adequately visualize all around the colon and there's liquid stool, I'm not going to call that test negative, right? Because I carry all the liability. So if the prep is not adequate, it has to be done again. Yeah, absolutely, I have some angry patients, trust me. But I tell them, if you're not clean, we're doing this again, right? I mean, I want someone to take some ownership. Listen, when I had my colonoscopy, I took an extra dose of the prep. I did not want my partner to see any kind of stool inside my colon at all. So it needs to be adequately cleaned. And the other thing that's important is that obviously some of these little polyps are small. They can hide behind folds in the colon. And it has been determined really in the American Society of GI that the hardest part of a colonoscopy is getting all the way to the end. So once you get all the way to the cecum, I then look for polyps coming out as I'm withdrawing. It has been demonstrated that if the endoscopist, with the total withdrawal time is less than 6 minutes, there's going to be a higher incidence of missed polyps. So if you're looking at a colonoscopy report and you want to see, like, did this meet standard of care? How do I know it met standard of care? Did somebody fall below standard of care? Number one, did they intubate the cecum and document that? Number two, was there an adequate bowel prep? Because these polyps can hide behind fluid or stool. And number three, was their withdrawal time greater than or equal to 6 minutes? And most GI software systems, once I hit the cecum, the nurse hits the button and I get timed. And if I don't take shorter than 6 minutes, because the more time you look around folds, you will find polyps. The other thing I'll mention that I don't have a slide is if I do 100 colonoscopies, what percent of the time am I going to find polyps? Am I finding them 2% of the time? Am I finding them 50% of the time? In general, it's about 20 to 25% of the time. So one thing to think about if you're whatever side of the fence you're on, plaintiff or defense, is look back at the particular endoscopist. Are they always finding polyps? Do they find polyps 100% of the time? No way. Are they not finding enough polyps? And everybody has that data. That data can be kept in the GI lab, and they keep data on us for everything that we do. But you should be about 20 to 25% polyps, meaning you're finding enough and you're not taking out things that are not polyps. So why do I say that? Remember, I came from the private sector. I get paid one fee for a colonoscopy, and I get paid a higher fee if I take out a polyp. There are some occasions where I've looked at some charts where someone has taken out normal mucosa. So if you have a doctor that's taking out a lot of normal mucosa, something is not right. Okay? Sometimes normal mucosa can look like a polyp, so I got that because I've had that happen to me before. When you suction through the scope, you can get some mucosa sucked up. It can look like a polyp, and we call that a suction polyp. So sometimes if you're not sure, just take it out because it's a lot easier. But those are some of the things that you need to look at. You should be able to tell by looking at a colonoscopy report if it was done within the standard of care. And again, I'll briefly end up here a little bit with informed consent. You know, it's not possible that I can tell you all of the possible problems that can happen with a particular procedure. The one thing that drives me crazy, however, is when a patient has said to me, you know, if they've had a complication, but I didn't understand the informed consent. Wait. It's an informed consent. It's not an understanding test, right? I mean, I don't mean that mean, but I inform you, you consent. It's not, did you understand what I'm talking about? Because sometimes it's hard for the medical students to understand. But that's why they're placed in there about, did I ask questions? Did he explain everything to me? But it's not an understanding test. It's I informed you, and you consented. The other thing that I teach some of the young doctors, and we only have a couple more minutes, is you can't possibly tell every patient from every surgery, every potential complication. These 6 things I actually write on everything that I do. If I'm doing a hemorrhoidectomy, if I'm doing a total colectomy, if I'm doing a liver resection, these are the things I write. These are the things that can happen to you anytime you do surgery. Bleeding, infection, anesthesia complications. I can make you worse because there is a lot of rare complications out there that I would not have predicted, that I've never seen, that I made the patient worse. I can injure another organ, or obviously death. Now, my anorectal patients that have to read that list are generally not happy with me. However, there's no such thing as a simple operation, and anything can happen, as you all know, in any of these things during surgery. And this tends to cover, certainly informed consent doesn't prevent medical legal action. We all get that. But certainly these things, if you go over with them, is a lot more helpful. So to conclude and wrap up here, obviously it's very important to understand what the issues are, who gets the colonoscopy, when is colonoscopy indicated, what would be the standard for performing a colonoscopy, what are some of the things if somebody met or exceeded or fell below the standard of care in colonoscopy. Make sure, again, some of these things are debatable amongst us. Obviously, the reason that you're all looking to get an expert is just to give you what's the bottom line, what should have been done, what is standard of care, because things change, things are different, and it's very important that, you know, when we're explaining these things to each other or to a jury, you know, if you make it simple, then I think it's a lot easier to understand. That's my picture. And now we're back to the Q&A.
Thanks, Dr. Cohen. if everyone can enter the passcode for today, which is colorectal, and any questions that you have for Dr. Cohen. Our first question, if I had a clear colonoscopy at 50, doctor says you have a beautiful colon, but I'm now 58 and experiencing occasional blood and stool, should I request a colonoscopy now or wait until I'm 60?
That is the best question I have heard, and I hear that question every single day, and I laugh about it because, yes, you absolutely need a colonoscopy because if you wait, the chances are you may have something 2 years from now, or if you have a little polyp causing the bleeding, you're cured. So that's a very important distinction. And I say that to patients. Listen, you don't need another one of these for 10 years, but if you have any symptoms, please tell me, meaning blood in the stool, change in the bowel, anything different. So absolutely you need a colonoscopy.
Next question. Can you address whether perforation is ever a breach in the standard of care, and if so, what factors make that so? Conversely, is a perforation always deemed as an unavoidable risk of the procedure?
Well, so yeah, that's a very good question. That comes up a lot. So perforation is a known risk factor of a colonoscopy. There's going to be, so there's two issues. Issue number one, there's a higher risk of perforation if you take a polyp out. Taking out a polyp weakens the wall a little bit. If I use heat or electric cautery, the way we're taught to do it is I grab the polyp, I pull it away from the wall, I burn the tissue and take the polyp out. There's either early perforation or delayed perforation. My first perforation happened 3 days after I took the polyp out. So that's thing number one. Thing number two, sometimes the scope itself, if you push hard enough, because it's flexible, the back end of the scope can bow up and tear the colon. But I will tell you that more often than not, if you have a perforation of the colon, that is a known complication, not below standard of care. The question is, when was it recognized? And there's where the rub comes in. Because I've reviewed cases where the patient has a colonoscopy polypectomy, they go home that night doing fine, they met discharge criteria, no issues. Midnight, they start having abdominal pain. They call the doctor. The doctor says it's gas, no problem. That's a problem. That's a problem. Therein lies. It's not the perforation that bothers me. It's the failure to recognize the perforation. If a patient has a problem after a colonoscopy, that mandates evaluation. You don't get gas 8 hours, 10 hours after your colonoscopy. Your gas is right away. So we had a rule, and this happened early in my career, it wasn't a medical legal thing, but the nurse that took the call at 4:55 told my colonoscopy patient in the morning, oh, that pain's normal, everybody has that. Seriously? No. If you have pain or some symptom after a colonoscopy, you need to be seen, you need to be evaluated. The perforation itself is not below standard of care. Where individual physicians, ER, GI, medicine gets into trouble is failure to recognize, failure to treat it. The earlier I can get to you, I can close the hole.
Next question. Regarding the standard of care, does the prevailing community standard warrant physical anal examination and visualization with a report of blood in the stool? Can you put that up there? About the
prevailing community standard warrant physical perianal exam. Oh, absolutely, 100%. Right. I mean, this is what I tell the residents. There's only two reasons why you don't do a rectal exam, especially having blood in the stool, okay? Number one, the patient doesn't have a rectum if something was taken out. And number two, if you don't have a finger. I mean, again, seriously, if you're going to listen to the heart and lungs and you have a report of blood in the stool, that mandates a rectal exam, and not to do that is below standard of care.
Next question. Can someone just request a colonoscopy at any time?
Well, there certainly have to be indications for the colonoscopy. It's funny the way that question's asked, because another thing I have all these things I tell the residents. Listen, you're going to get complications in surgery. That's fine. If you do enough surgery, I've had every complication, that's fine. But if and when you get a complication, the first question anybody asks you is, did the patient need the procedure? So you better be able to answer yes to that. So if you have a patient that's requesting a colonoscopy that does not have an indication to have it, and they have a complication, that's not defensible. So I don't know why you requested it at any time, and I don't know who's going to do it unless there's an indication for it.
And our last question. My gastroenterologist advised me that I didn't need any additional colonoscopies after age 68, even though I had polyps removed. I'm now 75. Should I insist on having them done anyway?
Yeah, so that's a very individual question. I mean, if you're 75 and you're healthy, and you probably are, then absolutely, because the guidelines usually it's about 76 to 85. Over 76, we don't recommend it anymore. So if you were told at 68 you don't need it, I don't know where that came from. That number to me was made up because I've never seen that before. The age is really above 75. But again, we're all living older, so I guarantee those numbers are going to tweak up. I mean, I hope I'm spry at age 75 or 78, but I tell you, if you're otherwise healthy, if you have if God forbid they find a cancer and you would do okay with a right colectomy or a partial colectomy, then absolutely have it, because if you've had polyps, the chance you've gone now a long time without another colonoscopy, the chance of you having a precancerous polyp is high. So absolutely. I tell you, if you were related to me and didn't have a lot of other comorbidities, I would definitely tell you to have it.
Thanks, Dr. Cohen. All unanswered questions will go directly to Dr. Cohen to answer them individually. In addition to being your best source for testifying and consulting experts for more than 60 years, TASA also offers free interactive webinars, expert written articles, research reports from expert witnesses, including the Challenge History Report 2.0 and Expert Profile 360. I would like to take this opportunity to thank everyone for attending, and most especially Dr. Stephen Cohen for his time and effort in creating this presentation. If you would like to speak with Dr. Cohen, or if you would like to speak with a TASA representative regarding an expert witness for a case that you are working on, please contact TASA at 1-800-523-2319. One of my colleagues will be following up with you regarding your feedback on today's presentation. Also, please remember that if you are applying for credit, you must have attended for the full 60 minutes of the presentation, and you are also required to complete the survey at the end of the program. Also, you should be receiving your certificates via email in 24 to 48 hours after the presentation. Thank you all for attending. This concludes our program for today.